Hello, everyone, and welcome to today's webinar, Sample Collection and Transport in the Age of COVID, a retrospective, What Have We Learned? I am Marie Stone of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Copan Diagnostics. To learn more, visit copanusa.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. This webinar is educational and thus offers free continuing education credits. Please click on the Continuing Education window at the bottom of your screen to obtain your credits. I'd like to now welcome our speaker, Dr. Susan E. Sharp, Scientific Director, Copan Diagnostics. Susan, you may now begin your presentation.
Well, thank you, and hello, everyone. I would like to start by thanking LabRoots and thanking Copan for asking me to present today, and to thank all of you for attending today. We're going to spend some time talking about sample collection and transport in the age of COVID. We're going to look at what's been going on over the last year and what we've learned from a sample collection age and basically over the history of the last year. So let's get started. We're going to have a few objectives today. We're going to go over again and make sure that we recognize what is the gold standard for sample collection for respiratory viruses. And then we're going to spend some time and go over how sample collection devices, the swabs themselves, the collection devices, as well as the transport media changed over time and with the FDA as we moved forward last year in the emergency use authorization process for testing. And lastly, we'll discuss a few issues, including the quality procedures that are used in swab manufacturing, self-collection of specimens, a little information about some at-home and over-the-counter testing that's available for COVID, and then just lastly talk about a few differences in the methodologies that we have out there for testing for COVID. So first, to recognize the gold standard for sample collection for respiratory viruses. And you might think that's kind of weird that I'm showing you a picture of soda when I'm going to be talking about swabs, but I do this to make a point. As you can see, these are all different types of soda or soda pop or whatever you call them, but obviously they're much different from one another. And the same thing can be said for swabs and collection media. There's lots of different types of swabs and many different types of collection media, and as we know with soda, all swabs and all collection media are not created equal. Swabs and collection devices do have to have an establishment registration and a device listing with the FDA. And this is just an example of one from Copan Diagnostics. And again, it's an establishment registration that lists the devices. This is for Copan. You can see that there's a registration number associated with that. And then at the bottom, it shows the different types of applicators and collection devices that Copan has listed with the FDA in this establishment registration. And again, that is required for all collection devices in the U.S. So let's start by talking about our traditional fiber wrapped swabs. Now these are swabs, as you can see, that have just a stick associated with them, and then the fiber is wrapped around the end of the stick to make this a mattress core, if you will. Now these spun or wrapped swabs are usually made out of polyester or rayon, and again, wrapping them onto the end of the stick, you'll see there's a swab at the end that is made up of a lot of these wrapped fibers, as you can see in the insert picture. Now, when you absorb a sample onto a traditional fiber wrapped swab, a lot of the sample will get trapped on the inside Although these can absorb a decent amount of sample, it's very difficult sometimes to get this trapped sample on the inside of all these different fibers actually out of the swab once collected. So Copan invented the nylon flocked swab. And as you can see here in the upper left, rather than being just a stick applicator, it has a molded head, as you can see here. And this is important because when the flock swabs are made, as you can see on the right-hand picture, we start with that molded head top. We then add glue to the top to that molded head. And at the next stage, we undergo what's called the flocking process. This is where you take very small little fibers of nylon and you flock them onto the outside of the molded head. So millions of these little fibers are blown onto the head of the swab that is covered with the glue, and they stick into the glue, and you end up with a swab that looks like this. So again, the flock swab is made out of nylon, and it's made out of these millions of very small nylon strands that are coated onto the head of this elongated swab here, or molded swab, as you can see. Now, flock swabs, as you can see on the left-hand side, come in all different kinds of sizes and shapes, depending on what you're going to use them for. And again, with the nylon flock swab, as much as 90% of the sample will elute out of the swab very rapidly. And again, this is because it doesn't have that mattress core that will maintain some of the specimen and not allow it to come back out. And that is shown in this slide. As you can see on the top, there's a traditional fiber swab. The sample, once it's taken with the swab, you put it into a liquid media. A lot of the sample will become trapped in that fiber mattress and not elute out into the liquid volume, as you can see in the upper panel. But with the flocked swab, excuse me, this brush-like texture efficiently collects specimens from the respiratory tract, including cells and fluid. The sample stays very close to the surface and elutes out very rapidly in the transport media, as you can see in the slide on the bottom right. Much more of the specimen was actually eluted off of the flock swab than is able to be eluted off of the traditional spun or wrapped swabs. Now, I'm going to talk a little bit about absorption and elution volumes later, and then I'll tell you a little bit later about why this is so important in the swab manufacturing process. But with the swabs, we're all aware that there's regular type swabs, as you can see in this picture. They can be, again, made out of that wrapped or spun fiber that makes that mattress core. They can also be made out of foam, or they can be made out of the flock process, which I just described to you. So in the center, you can see the absorption volume for each one of these regular type swabs. And the regular type swabs would be a swab that would be used for a nasal specimen or a throat collection specimen. And as you can see in comparing these three different types of swab, that the regular flock swab absorbs the most volume, over 150 microliters is absorbed onto the swab, compared with foam, which absorbs only 38 microliters, and a regular traditional wrapped fiber swab or spun swab, which will absorb around 100 microliters. And then if you look at the release volume, again, the regular wrapped fiber swab will release around 58 to 64% of its specimen that it absorbed. The foam swab releases about 85%, but again, the flock swab releases the maximum amount of specimen. 94% of the specimen that is absorbed onto the flock swab will then be eluted into the specimen, into the transport media. Also, if you look at the mini-tipped swabs, these are the swabs that would be used for a nasal pharyngeal collection, for example. So they have a much smaller tip on the end, as you can see. And again, these mini tips can be made, again, from wrapped fiber, or they can be made from flocked nylon. And again, looking at the absorption volume, you can see that the traditional mini-tipped wrapped or spun fiber swabs absorbs about 25 to 30 microliters as compared to the mini-tipped flock swab, which will absorb 64. And again, much better release volume or elution volume associated with the mini-tipped flock swab at 96% compared to the fiber-wrapped swab at 65 to 70%. So that was talking about the swabs, and as I said, they're not all created equal, and now you understand why. There's also a variety of different transport media that have come into use during the COVID pandemic. And first is viral transport media. This is an example of UTM, which stands for Universal Transport Media. It is an FDA-cleared collection and transport system that's suitable for the collection and transport of specimens to the laboratory, either at room temperature or at refrigerator temperatures. And you can also maintain these in long-term freezer storage for weeks to months as well for your clinical specimens. Now, viral transport media is an open platform. This type of a specimen collection can be used either for viral culture, for enzyme immunoassays, for direct fluorescent antibodies, and even for nucleic acid amplification tests or molecular tests. And numerous studies are out there that have showed that if you take a UTM, viral transport media, and you pair it with a flocked nasopharyngeal swab, so one of those mini-tip flocked nylon swabs, that it is equivalent to nasal aspirates and nasal washes for the diagnosis of respiratory viral infections. Now, Amy's media is a media that's been around a long time in microbiology. For Copan, we have Amy's media included into our eSwab, which is a flocked swab with 1 ml of Amy's media in a plastic screw cap tube, as you can see in the picture. Now, this is normally used for the collection and transport of aerobic, anaerobic, and fastidious bacteria to the laboratory for up to keeping the organism stable for up to 48 hours. But you'll see in a slide coming up that Amy's media was also used for a collection specimen early on in the COVID pandemic. Another media is nucleic acid stabilization media, and these are guanidine thiocyanate-based media. Copan also produces one of these types of tubed media called the ENAT. And again, because it does have this guanidine thiocyanate in it, it stabilizes both RNA and DNA of viruses and bacteria. So it ensures the preservation of the nucleic acid at room temperature for weeks or even months if the specimen is frozen. And one thing to remember about these guanidine thiocyanate-based mediums is that they do inactivate microbial viability and activity. So it allows for safe specimen handling, but you will not be able to recover the organism or grow the organism from these nucleic acid stabilization media. And one other note about these stabilization media is that the FDA has put out a note about the use of these media in the laboratory. This transport media, these that have the guanidine thiocyanate, if it is exposed to bleach, it can produce a very dangerous cyanide gas. So there is a warning associated with these types of collection media when used for COVID diagnosis, especially on two high throughput platforms, the Hologic Panther and the Panther Fusion systems. They do use a disinfection step of bleach on their platform. So again, because bleach can interact with the guanidine thiocyanate in the transport media and produce that dangerous gas, it is recommended that these stabilization medias are not used with either one of these two platforms. So our second objective was to talk about and describe the generation of the different specimen types, collection devices, and transport media that evolved early on during the COVID pandemic. So everyone remembers that very early on, the first emergency use authorization assay for COVID that was authorized by the Food and Drug Administration went to the CDC, and this was early in February of last year. That assay used either a nasopharyngeal swab or an oral pharyngeal swab or a throat swab that was made out of nylon or polyester and the specimen had to be transported to the laboratory in a viral transport media. And after that first assay, additional swab types, collection sites, and transport medias were then also given emergency use authorization by the FDA. So let's talk about those. So again, as I already said, the CDC assay was the first emergency use authorization given by the FDA. At that time, the specimens had to be collected by a healthcare worker. Again, they could be nasopharyngeal or oral pharyngeal collection by the healthcare worker. They could be flocked nylon swabs or polyester swabs in viral transport media. Now, soon after the CDC assay was given an emergency use authorization, the FDA also added on the ability to use either liquid amines, came first, and then phosphate buffered saline came next. Again, due to the overloaded specimens and the difficulty in getting viral transport media, there was data out there to show that liquid amines would also hold viruses stably for a number of hours or days, and also phosphate buffered saline. So the FDA did authorize the use of these other two transport medias early on as well. After this, the mid-turbinate swab, which is also a flocked swab, which goes halfway between the anterior nares and the nasopharyngeal part of the back of the throat anatomy. So it goes halfway between, so it's called the mid-turbinate. It's a flocked swab, was also approved for use, as were nasal swabs. And in addition to the nylon flocked or polyester swabs, the FDA in March, later on in March, also approved the ability to use a foam swab as well. By early April, the CDC also authorized another transport media to go along with the viral transport media, the liquid amines, the phosphate buffered saline, and they added normal saline as well. By the middle of April, they also added another collection type of material that could be used for nasal swabs, and that was be able to use rayon. So not only could we use nylon, polyester, foam, but by mid-April, rayon was also approved, as was another transport media, which was the nucleic acid stabilization media that we've talked about. And then in May, up until this time, most of this testing had to be done by a healthcare worker, either at a healthcare facility or at a drive-through facility. And in early May, the FDA also approved the use of home collection for some COVID assays as well. So home collection of the specimens that you would then send in to the laboratory for testing. So the FDA continues to indicate to us that the sample collection with a flocked swab, when available, is preferred, but there are other types of swabs that can be appropriate for collection as well, which are listed here on the slide for you. Again, a nasopharyngeal specimen should be collected by a healthcare worker using one of those specialized mini-tip swab, and again, according to the FDA, the nasopharyngeal flock swab is still the collection of choice. But you can also use oral pharyngeal specimens or regular sized swabs, full tip swab. And these originally were also needed to be collected by healthcare providers. Mid-turbinate specimens also should be collected by a healthcare provider, or they can be collected on site by the patient themselves under the supervision of a healthcare worker using a flocked mid-turbinate swab. Lastly, as we said, the FDA did approve anterior nares specimen collections with a routine a full-size tip swab. Again, this can be collected by a healthcare provider or on-site self-collection using a full-size flock swab or a round swab or a fiber-wrapped swab. And we know soon after this, home collection of nasal swabs came later, as well as did home testing, and we'll talk a little bit about those in a bit. So I'd like to go over a few studies on this slide and the next slide to give you an idea of what formed these initial FDA guidances. There were some papers published in the literature early on, and the FDA used some of these papers to help inform their guidance on specimen collection for COVID. The first study was done at the Everett Clinic, and they wanted to evaluate self-collection from different sites in the body. So they looked at nasopharyngeal collections, nasal collections, mid-turbinate, and tongue collections. Now you can see on the swab type, I have comparator on this slide next to the nasopharyngeal in a yellow highlight. And that's because I wanted to point out that in this study, they did use a nasopharyngeal to compare the rest of these swabs and the rest of these collections to. But the nasopharyngeal swab they used in this particular study was a fiber-wrapped swab. So it was not a nylon flock swab. So just keep that in mind as we go through. So they wanted to compare these different types of swabs from self-collection that were then put into viral transport media and tested at the laboratory. And as you can see over to the far right, as compared to the wrapped swab that was collected by the healthcare worker and then compared to these other collections, a self-collected mid-turbinate specimen had about 96% sensitivity as compared to the healthcare collected fiber-wrapped nasopharyngeal swab. A self-collected nasal specimen had about 94% accuracy as compared to the nasopharyngeal swab, and the tongue collected specimen was not very good. The sensitivity of the tongue collected specimen fell well short, being less than 90% when compared to the nasopharyngeal swab. The next study, the second study, was done at Stanford. They wanted to look at, also at self-collection from nasal passages. So they compared throat-collected specimens to nasal foam-collected specimens, also submitted in BTM and tested in the laboratory. And they found that the nasal swab that was collected by the healthcare worker was equivalent to the oropharyngeal swab, also collected by the healthcare worker. They also found that the nasal swab, if self-collected, was also equivalent in sensitivity to the throat swab collected by the healthcare worker. So again, you can see these studies informed what types of specimens could be collected, what kind of swab should be used, and what type of transport media can be used. The third study was again done at the Everett Clinic, and the Everett Clinic is in Seattle in Washington State, one of the very first outbreaks of COVID that was seen in this country. So the second study they did at the Everett Clinic in Seattle was to evaluate alternative polyester swab and evaluate alternative transport medias. So again, they looked at all nasal specimens in this third study. They looked at foam and polyester submitted in viral transport media, and then they looked at foam and polyester nasal swabs submitted in saline. And they were able to show that the polyester swab was equivalent to the foam nasal swab when submitted in BTM, and that also the polyester swab was equivalent to the foam nasal swab when submitted in saline. Again, giving more information to the FDA on what was appropriate specimens to collect, either foam or polyester, and also saline worked quite well as well. The last study on this page also wanted to evaluate the impact that heat might have on these specimens. So they looked at nasal collected specimens, again, from COVID patients. They looked at foam collections as well as polyester collections, submitted dry and in saline, and tested in the laboratory. And as you can see in the little chart on the bottom right-hand side, that at 32 degrees, slightly above room temperature, the foam dry swab, the polyester dry swab, and the polyester saline swab, the first two that were dry, the virus was stable for up to 80 hours at 32 degrees, went down a little bit with the polyester saline swabs, went down to about 56 hours of stability at 32 degrees. But look what happened to all three of these types of specimens when they were transported at 40 degrees, much higher. You can see that the stability of the samples to be tested in the laboratory were only able to be maintained for up to 12 hours. The last two studies I want to share with you, there was a big study done by Quest early on during the pandemic where they evaluated the stability of the virus and transport media under various storage conditions. What they did is they took nasopharyngeal specimens, throat specimens, sputums, and sputum specimen and BAL that they received, tested for COVID that were negative, and then they spiked these samples with COVID virus and tested them in the laboratory. They used a variety of different swab types. They used a variety of different transport media. They used UTM, M4, they used amines in eSwabs, and they also used saline. And they tested these in the laboratory. And overall, with these spike samples in the transport media, they were able to show that the CT values were stable when the specimens were stored at -30 degrees Celsius all the way up to 25 degrees Celsius for up to 7 to 10 days. So good stability when stored appropriately. And then the last study I want to share with you, also out of Seattle, evaluated the use of dry mid-turbinate flock swabs compared to those swabs that were submitted in VTM. This is for studying the impact that a dry swab might have in home collection kits. And their preliminary results demonstrated that the dry swabs would indeed support detection of SARS-CoV-2 for a limited amount of time without impacting the sensitivity of the assay. So our last objectives today, we're going to talk about a few other issues that we went over when we talked about our objectives, but the first one we're going to talk about is quality procedures in swab manufacturing. As I said, swab collection devices are considered Class 1 devices by the FDA, and as such, they do have requirements that have to be met in order to get this device listing in order to meet these requirements. Analytical studies must be done, sterilization studies must be done, and then packaging and labeling studies must be done and submitted to the FDA. So first, the analytical studies. These studies are done because we know that swabs need to be certified to be non-toxic, non-irritating, and non-sensitizing for limited contact that they're going to have when they come in contact with the human, whether that's the nasal passages, the throat, the nasopharyngeal, etc. And Copan goes to great lengths to ensure that all components, including our glue, our fiber, and our plastics, comply with very rigorous biocompatibility standards that are necessary from the FDA. Another area of importance and high focus for Copan is mechanical safety. Continual quality control is performed to ensure that certain mechanical standards are met, including applicator flexibility, fragility, fiber detachments, and durability after sterilization, including tensile testing, torsional testing, and flexural testing. And this will become important in a couple of slides when I talk to you about another study that was done. Swabs also need to show equivalent performance and adequate collection of specimens from their intended site, whether that be nasal, nasopharyngeal, oropharyngeal, etc. So fluid dynamics, as we've already talked about, absorption and release, these fluid dynamics are huge for consideration for manufacturers. And manufacturers must quantify fluid dynamics for all of these slides. Additionally, Copan has decades of experience as well as a fully equipped molecular biology laboratory to ensure that none of our swab components interfere with the chemistries of any of the molecular assays or antigen assays. As part of our quality control program, we continually test our swabs with numerous molecular platforms to ensure that we do have compatibility with all of these different platforms. Now, the sterilization process must be validated by the manufacturer prior to distribution, including the bioburden testing of the final product, which you can see here in A panel. That's before the final sterilization product, and B, after the final sterilization product. And this is something that's really been taken for granted in the industry for a long time. But during the pandemic, we all remember seeing these headlines about contaminated or non-sterile medical swabs being used for COVID diagnostics. Packaging and labeling is also important, as I said, for getting a device listing with the FDA. Packaging must address the seal strength, so the packaging sealing of the product must be adequate. And it also addresses the integrity of the packaging to make sure that it will hold up during the shipping process. And swabs also must be labeled appropriately, which will include their intended use, whether they're for nasopharyngeal specimens or whether they're for nasal specimens, throat specimens, etc. So it also has to be labeled to include what the site of application of the collection device is for. Now, during COVID, we know that there were severe limitations and supply issues with getting enough swabs for the height of the pandemic, which we went through last year and we're going through again currently. So 3D printed swabs became very popular and were being looked at by many different individuals. As you can see here, there's a lot of 3D printed swabs here. These, again, are completely made of plastic on a 3D printer. Now, when you look at 3D printed swabs versus the conventional swabs that we normally saw in manufacturing, there were some user concerns that were reported to the FDA. First, it looked that like some of the 3D printed swabs are very brittle, especially after they were sterilized. They became very brittle and they would break into multiple sharp pieces, which could injure the patient. And also the non-traditional heads, as you can see in the picture, associated with these different types of swabs were concerned that they were not appropriate to sufficiently absorb enough specimen actually to test appropriately in our testing devices. We know that there was limited experience and research with these types of 3D printed swabs, although we know we have a lot of research over the many decades with using traditional swabs. We didn't have a lot of that same information for using these 3D printed swabs for diagnostics. And it is important that these swabs be assessed to ensure that they are appropriately characterized for, again, their intended use and to make sure that they do meet the clinical need. And there has been a consistency in these devices also been reported saying that if a device, even if they use the same recipe, if you will, if they're produced at different facilities, they can have different characteristics that can affect safety and efficacy. And that finally, the finishing and the sterilization process associated with the 3D plastic printed swabs, even printer updates that may take place, are among some of the factors that could affect how these swabs would function in real life. And because of these concerns, the FDA, on the bottom of the slide, you'll see there's a link there for you, did publish some guidelines on some technical considerations for manufacturers that were making 3D printed materials during the COVID epidemic, including the 3D printed swabs. Now, as I stated, swabs are a Class 1 device that are registered and listed with the FDA. And this was a very interesting study that looked at the quality and the performance of collection swabs and viral transport media from unregistered manufacturers. They looked at 5 different manufacturers. And they specifically looked at the assessment criteria to include an inspection of the device integrity. They looked at the determination of the swab and the viral transport media as far as sterility is concerned and their in vitro performance. They looked at the stability associated with the viral transport media, and then overall the clinical performance of the device kit, so the swab and the viral transport media together. They did use as their gold standard the FDA registered Copan VTM or universal transport media and a Copan flocked swab as their comparator. And you can see here, this is table 4 from that published article that gives examples of the issues that were found with these unregistered products. You can see with manufacturer 1, there were 3 out of the 10 swabs that had growth observed in cultures, so 3 out of the 10 swabs were contaminated. They also found that they looked at 10 different viral transport media from this manufacturer, and again, all 10 of them were also heavily contaminated with organisms. Manufacturer 2, about 13% of the viral transport media containers had visible leakage, or they were inconsistent in their fill volumes. Same thing with manufacturer number 3, 4% of the viral transport media containers had either visible leakage or had an inconsistent fill volume associated with them. With manufacturer 4, they again saw visible growth or discolorization and leakage in a number of the viral transport media containers. And then in 5, they looked at the integrity and also the in vitro performance of the swab. They found with the 3D printed swabs, which was the swabs that were used from manufacturer number 5, that there was breakage of the stem outside of the breakpoint, and that these, can be a safety hazard for the patient. They also had very limited flexibility of the shaft of the swab. And they also found that they had very poor transfer effectiveness. So they didn't pick up a lot of swab, and they didn't transfer a lot of swab to the viral transport media. They were able to show that the CT values were 3 to 4 cycles higher than that of the referenced flock swab that they used as a comparator. Now, there was also a recent meta-analysis performed by Lee and colleagues that reviewed a tremendous amount of literature surrounding specimen collections for the diagnosis of SARS-CoV-2 infection. And they were able to include in their analysis 25 citations that evaluated and studied the use of saliva, 11 articles that looked at nasal swabs, 6 articles that looked at oropharyngeal swabs, 4 of them that looked at oropharyngeal and nasal swab specimens that were combined. And all of these were compared to nasopharyngeal swabs as the gold standard. Now, 3 specimen types that were studied all showed lower positivity rates as compared to the nasopharyngeal specimens. The nasal swabs at about 82% sensitivity, the throat swabs or the oropharyngeal swabs at 84% sensitivity, and saliva at 88% sensitivity. Now, the combination of the throat swab and the nasal swab came closer to the sensitivity of the nasopharyngeal collection with a performance of 97% sensitive. Now, of note, nasal swabs in these studies that specified that they used a flocked nasal swab had a substantial higher positivity rate than studies where an unflocked nasal swab was used. And this again shows the superiority of the nylon flock swab to absorb and release specimen as compared to our wrapped fiber swabs. So these authors concluded that nasopharyngeal specimens remain the gold standard for the diagnosis of SARS-CoV-2. And although there are alternative specimens that might be promising, we still have a lot to know about the impact of the variation of these different types of collection devices, the variation of the people that are actually collecting the specimens, whether that be a healthcare worker or self-collection. Processing protocols in laboratories are different, and obviously the populations that are being tested are also can be very different as well. So one of the last objectives we're going to talk about was home collection. Home collection has been around for many months now, if you will. There are several home collection kits that do have emergency use authorization from the FDA, and they come with some general outlines of how to collect a specimen. These are usually always anterior nares specimens that are tested at home in our community setting. So again, they usually use a swab. The swab is either placed in a dry tube or a media tube and then is sent to the laboratory in the mail. And you notice I have a little red star there, and we'll talk why that's important. Remember, we had that study that looked at the stability of the viruses being transported at 32 degrees as opposed to 40 degrees centigrade. And again, most of these will come with some instructions, as you can see on the right-hand side, to Carefully open the nasal swab so you don't contaminate the end that you're going to collect with. To gently, insert into one nares until you feel a little resistance. Swab it around about 4 times. Remove it, and then do the same thing in the other nostril. Place the swab with the swab tip first into the media, break it off, put the cap on it, and again, then put it in a mailer and send it to the laboratory. And the reason it's so important to understand with these, the effect that temperature can have on these specimens is because this is was taken in July 19th of last year during the height of some of the COVID issues that we were having in the United States. And this simply shows how hot some of the delivery trucks can be. This was labeled a heat taking its toll on a UPS driver that has no air conditioning. And if they don't have any air conditioning in the front of the truck, they don't have any air conditioning in the back of the truck. And you can see that the temperature reached 152 degrees Fahrenheit in the back of the truck, which is 67 degrees centigrade. And remember the study I showed you about the significant decrease in stability of the virus and the viral nucleic acids when the temperature increased up to even in the 40s. You can imagine what might happen to the stability of the virus and the stability of the specimens when they're transported at 67 degrees centigrade. So something we need to keep in mind when we do home collections and then have them sent into the laboratory for testing. Now I want to review some at-home tests that have gotten some emergency use authorization from the FDA. There are 2 different types of at-home tests. They can either be tests that are done by prescription, so your healthcare provider would prescribe one of these tests for you and you would do the testing at home. Or there's also now over-the-counter tests where you do not need a prescription from a healthcare provider. You can simply walk into your pharmacy, pick up one of these tests, take it, purchase it, take it home, and do your own test at home. So there's several examples. I'm just going to go over a couple of them for you. In November of last year, a molecular prescription at-home test was given an EUA, or an emergency use authorization, by the FDA. And this was from Lucira Health that invented this one. Just briefly, this is how the results are read. Again, there's very good instructions on how you collect the specimen, the nasal swab specimen, how you do the test. But I wanted to show you this last slide where you would read the result. And this test, again, is a molecular assay that is done at your house. The test will be ready in about 30 minutes after you set it up. If the positive light goes green, as you can see on the left-hand side, and the done button is also green, that is a positive result. In the middle, if the done button is green and the negative illuminates green, then that is a negative test. On the far right, you can see if all lights are flashing green, then that is an invalid test. So you cannot determine positivity or negativity from that. And again, in their instructions, they'll tell you what to do if you're positive, what to do if you're negative, and then how to dispose of the kit. So again, an at-home prescription molecular assay. There's also some at-home prescription antigen assays that are also available that have gotten emergency use authorization from the FDA. 2 of them are listed here for you. One from Quidel Corporation, which was given an EUA from the FDA in early March, and then one that you're probably familiar with too, the Binax Now Antigen Card Home Test from Abbott Diagnostics, which received its EUA for prescription at-home testing in December of last year. And these are both lateral flow visual reading assays. Quickly, to go over the quick view. Again, it comes with instructions on how to do the test, wash your hands, get your components ready, take your tube out, stand it up in a little platform, a cardboard container that comes with the kit. Again, take your nasal swab with instructions on how to appropriately sample your nares for the test, take the swab out, stick it in your media, let it sit there for a minute or so. Then you take the swab out and then you add in your lateral flow strip. You wait for an appropriate amount of time, 10 minutes, I believe, in this assay, and then you interpret your result. And it has very good instructions on what is a positive result. You have to see both a blue and a pink line in order for it to be positive. If you see only a blue line, like on the bottom left-hand side, that is a negative reaction. And if you only get a pink line and no blue line, that would be an invalid result. So again, an antigen test for prescription that you can do at home. There are some over-the-counter assays as well that you do not need a prescription from a healthcare provider in order to do this test. There are a few. This is the antigen over-the-counter test that you can pick up in your drugstore from Illumina that was given an EUA in February of this year. And again, it's an antigen lateral flow assay. And there's also another molecular assay that is over-the-counter, not prescription, that was given an EUA by the FDA in March of this year from Q Health. And I just want to spend the next slide showing you the Q Health assay. It's really quite fascinating. Again, it's not prescription, so you can pick this up in your drugstore. On the far left-hand side, you can see that it comes in a box with two different packages inside. The first thing you do is that you download the Q Health app to your smartphone. Okay, and then you pair the Q Health app to the cartridge that was in the box that you just purchased, and that will pair by Bluetooth. And then you connect your reader, your cartridge reader, to a power supply. As you can see in the middle, you take your the test cartridge, you put it into the reader, you connect the reader, and then you take your swab, as you can see on the right, you collect your nasal specimen. On the bottom, you take that nasal specimen, you stick it into the test cartridge that is sitting inside the reader, and in 20 minutes, again, you will get an answer back to your iPhone as to the result of the test. So the last thing we're going to talk about is the different types of assays that are currently available on the market and in laboratories. So these are all COVID-19 assays that have an EUA from the FDA. I should mention there is one full approved FDA kit. It is not an emergency use kit. It has gone through the full FDA approval. And again, it's a test, it's the BioFire assay that is done inside the laboratory environment. But we know for our COVID assays, we have molecular assays, antigen assays, which we just talked about, and also we have our antibody and our serology assays. Now, our molecular or antigen assays can be used for diagnostic testing, for screening, or for surveillance. So as briefly, our molecular tests, we know that they do detect nucleic acids. They're usually more sensitive than our antigen tests. They will pick up your pre-symptomatic individuals sooner than your antigen tests will. Certainly, they will detect your symptomatic patients, and you may stay positive with a molecular test into convalescence as well. Confirmation is usually not needed with a molecular test. Our antigen tests, we know, rather than detecting nucleic acids, will detect proteins associated with the virus. They are less sensitive than our molecular tests, and confirmation may be needed with a molecular assay if, in fact, you have a patient that has signs and symptoms of COVID, you do your antigen test and it is negative. The clinician might be advised with these tests that if the symptoms do look like COVID and you get a negative antigen test, that you may want to confirm this with a molecular assay. Now, as I said, there's different types of diagnostic testing for COVID. Diagnostic testing is when testing is done on an individual when there is reason to suspect that they might be infected with the COVID virus. So you're testing symptomatic individuals or individuals who have had a recent exposure, or people that are at high risk, such as healthcare professionals that are taking care of sick patients. And again, you do this to determine what you're going to do with the patient. There's also screening that can be done. And this includes broad testing of asymptomatic individuals that do not have a known exposure. But again, these are also done with the intent of making individual decisions based on those test results for those patients. And then lastly, there's surveillance testing, and this is used to monitor for an occurrence of an infectious disease outbreak. So usually they're not single patient identifiers associated with these, but it's usually a large testing involving a whole community at one time, et cetera, rather than testing on an individual level. Now, diagnostic testing and screening testing do need to have FDA emergency use authorization or FDA approval. Surveillance testing, when you're doing community testing out in the community, is not under the FDA purview, and that does not need an EUA. But remember, with surveillance testing, you're not testing individuals, and you're not reporting results back to a healthcare provider so that individual decisions can be made on an individual. That is only happening with diagnostic and screening testing. Lastly, we know that there's antibody tests or serology tests that are also available that have EUAs from the FDA. And we know that the antibody test will look for the presence, or a serology test will look for the presence of antibodies in the blood of a person to detect if the body's immune response has detected the infection and is reacting. As we know, serology testing does not detect the virus itself, but only the antibodies we make to the different viral components. So in early days of an infection, when the immune response is still building up, serology tests may be negative if the antibodies are not at high enough volumes to be detected by the assay yet. And two things to keep in mind with serology or antibody testing, that currently antibody testing should not be used to diagnose or to exclude active COVID infection. So you don't use serology to diagnose COVID infection. And currently, this could change in the future, but currently, serology tests should not be used to indicate the level of immunity or the level of protection from the virus due to either a vaccination or due to a previous infection. There are several groups out there studying how we can use serology tests to determine immunity, but currently to date, the FDA has not given any emergency use authorization to any serology test to indicate any level of immunity, again, from vaccination or from previous infection. So again, with SARS-CoV-2 diagnostics, we start with a good collection. So whether you're using the gold standard of a nasopharyngeal specimen on a flocked swab, or you're using some other type of site or a swab like a nasal swab, a throat swab, collected on flocked nylon, rayon, dacron, or foam. You could also be using saliva collection or throat washes or gargles, as well as 3D sampling devices. This can be, again, as we've talked about, submitted to the laboratory in a variety of different stabilization media, such as viral transport media, saline, PBS, nucleic acid media, or indeed can be submitted dry. So I hope I've impressed on you that the collection and transport devices are truly essential components of the pre-analytical process for quality microbiology testing for not only SARS-CoV-2, but for other respiratory viruses as well. And with that, I would like to thank you all very much for your attention today, and I'll turn it back over to our moderator.
Thank you, Susan, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. Let's get started. Our first question is, what is the saturation volume of each swab type?
Well, thank you for the question. And this might have been asked before I went over this information, but in the presentation on slide 13 and 14, you can see that I've listed the absorption and the elution volumes of both the regular size swabs. Those would be the swabs that would be used for nasal, nares collections and also throat collections, and also for the mini-tipped swabs that would probably be more apt to be used for the nasal pharyngeal collections that go back further into the nasal passages. So if you want to check back on slides 13 and 14, I have wrap swabs as well as foam, as well as the flocked nylon fiber. in regular and mini tip that have both the absorption and the release volumes for you.
Okay, thank you. Next question. Will the self-collection home collection receive FDA authorization in the future beyond the pandemic? And also, will self-collection still be popular amongst test centers after COVID?
Well, that's a good question, and I think that's anyone's guess. I think right now all the home testing and home collection devices from that the FDA have put out are all emergency use authorizations. We know that companies now, especially for their assays, are putting in 510Ks to get full FDA approval. I think, as I mentioned, the BioFire is now an assay that does have full FDA approval that includes detection of COVID-19. I would imagine there's more test manufacturers that are working for that 510K clearance, and I wouldn't be surprised if there will be collection methods out there as well that currently have an EUA that will be looking forward to try to get a full 510K approval from the FDA. So I think it's kind of, we've opened this box and we start doing it this way. The genie's out of the bottle, if you will. It might be a little bit difficult to put the genie back in the bottle, but I guess time will tell. But I would imagine that some of the suppliers will be trying to go forward with FDA full approval for their collection devices as well.
Okay, thank you. Next question. We've recently received questions regarding the safety of the sterilization method used for swabs. Can you comment on how swabs are sterilized and the safety of the sterilization method?
Yes, this question we've received recently as well, so thank you for asking it to give us the opportunity to address this. There is some misinformation out there about the safety of the sterilization method used on swab collection devices. Swabs are sterilized using ethylene oxide, which is a gas, and it's extremely common when sterilizing medical equipment, so very commonly used. And while ethylene oxide can have a carcinogenic effect on an individual if they're exposed to very high concentrations for long periods of time, there's no danger from the brief use of a nasal swab in an individual. You can think of it kind of like a bit like using bleach at home. We know it's not a problem to dilute out bleach or other detergents to sterilize our surfaces in our kitchens and our bathrooms, etc., but no one would think about drinking bleach. We know that would be incredibly dangerous. But we also know that it's safe to use when you use it carefully and correctly, very much like the highly regulated ethylene oxide sterilization process that we use in swab manufacturing.
Thank you for clarifying that. Our next question, in-home collection, how is adequacy of the sample made sure?
That's a good question, and I don't know that there is a way to do that. Certainly for home collections, if they're sent in to a laboratory, a CLIA laboratory for molecular testing, of course, there's the human gene that is assayed for in many of those molecular collection, and if the human gene is not detected, then the assay is not able to be read. So that's one way that you can assure that that there has been specimen added to the swab. For antigen tests, rapid antigen tests, or other antigen tests, that is not available. So in those particular cases, there's really no way of really determining adequacy of the sample.
All right, thank you. Our next question. You mentioned PB saline and UTM is one better than the other. Are there still supply issues regarding UTM? UTM has been around for a long time, and we know UTM was originally developed to stabilize viruses for long periods of time for viral culture. It has been used for decades now in molecular testing as well. We have a lot more information out there on the use of viral transport media and UTM for molecular assays, a ton more than we have with PBS. So I would say that just because of the information that we have, that UTM probably does work better than PBS. There are probably, I think the Quest study that I went over in the paper, if you look at the details of that study, it may give you some comparison of using saline or PBS compared to some of the viral transport media. But with Copan, we've tripled our COVID-related production in 2020, both of our swabs
and our UTM media. And we have a goal for this year to reach 1 billion of flock swabs and 1 billion of spun fiber swabs and 1/2 billion of universal transport media to be produced in this year. So manufacturers have really geared up over the last 18 months, and there should not be an issue with supply chains for UTM and swabs going forward into the future. Now, that's a caveat. Of course, things could change, but with all the ramping up that the manufacturers have done, it is really time to get back to make sure we're collecting using listed, registered products that we know have quality in order to do our viral testing for respiratory viruses.
Okay, thank you so much. There have been some questions about the slides being made available, and this webinar will be available on demand. There will be an email sent out shortly. So it looks like we are out of time for more questions. Thank you again, Susan, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Copan Diagnostics, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.